So please welcome Dr. Wei.
Ladies and gentlemen, I'm Dr. Wei and a neurologist. I'm very honored to chair the topic. According to the previous experience, Professor Matsuda always prepare special, interesting, and important clinical cases for audience. The talk has award quizzes. If you know the answer, please quickly raise your hand. Dr. Hong support the special gifts to the winner. Please welcome Professor Matsuda continue the talk. Read with experts neurology for quiz.
Okay, let's start the read with experts neurology. So the first case, a 88 man, he has a complaint of forgetfulness and visual hallucinations for the past 4 years. He presents with hand tremors and muscle stiffness. Orthostatic hypotension and constipation had preceded these symptoms. So clinical history is very typical for some disease. So MRI T1 with the images, so MRI and VS already. Significant atrophy area is colored. FDG PET. So okay. So the magnified FDG PET. What do you think? This amyloid PET. Amyloid PET. This is amyloid PET. Positive or negative? Rather, maybe easy. So, what diagnosis is most likely? If you can answer, please raise your hand. Please raise your hand.
Please raise your hand.
Especially the young scientist, young. Some my book. Yes, that's right. Correct answer. DLB. So summary of neuroimaging. So no one. History is no typical, and MRI no atrophy in the middle temporal lobe.
Sorry, Professor, I have some
The mild hypometabolism in the occipital cortex, and amyloid PET, amyloid positive. Dementia with Lewy bodies associated with Alzheimer's pathology. So you can see FDG PET, somewhat decreased metabolism in the occipital cortex and preservation of the posterior synovial. So we call a cingulate island sign. So the amyloid PET, the positive even in the dementia with Lewy bodies. So the 50 in this report 57%, but some report reported the 80% of DLB is amyloid positive. So the coexistence of amyloid pathology, Alzheimer's pathology is very common in Alzheimer's in DLB. Okay. First case is the second case. Early 70s man, difficulty saying familiar words or recognizing familiar objects. Personality changes, irritability, MMSE is 40. So let's MRI T1 weighted to images and VSRAD. The FDG PET, this FDG PET magnification. Very characteristic pattern for some disease. So the brain function spect, so ages. Amyloid PET, negative or positive. So what is the most likely? A, Alzheimer's disease, B, dementia with properties, C, frontotemporal dementia, D, normal pressure hydrocephalus. Please raise your hand. はい、どうぞ。OK. Frontotemporal dementia. Okay, you are correct. To summarize the neuroimaging, MRI anteroinferior temporal lobe atrophy with left side dominance. FDG PET hypometabolism in the anteroinferior temporal lobe on the left side, predominantly in the left temporal pole. Brain function spect hypopoesion in the left temporal pole, amyloid negative. Frontotemporal dementia, the semantic type. So again, so this pattern is very typical for semantic dementia, left temporal pole. Sometimes it's the right side. So the left side is a language dysfunction. So semantic dementia is a subtypes of frontotemporal dementia, characterized by loss of semantic memory in verbal and non-verbal domains. This is amyloid negative, so TTP43 positive cases are very common. So okay, smart dementia. Third case, early 70s man, forgetfulness for 1 year, frequent impairment of consciousness lasting 1 to 2 minutes, disorientation, impairment in delayed recall, memory is 26, not within normal limit. So frequent impairment of consciousness. MRI. So MRI. FDG PET. FDG PET. Amyloid PET. Negative or positive. Okay. What diagnosis of most likely? Epilepsy, Alzheimer's disease, dementia with the bodies, frontotemporal dementia. If you can answer, please raise your hand. Anybody? Okay. Please. Epilepsy, okay. You are correct. So, summary, the bilateral atrophy of middle temporal lobes. FDG PET is no single abnormality, amyloid PET negative. So after that, electroencephalogram was performed, spike waves in the temporal lobe epilepsy in this case. So maybe some clinical seizure is occurred, taking place in this case. So the metabolic activity is a little bit increased. So there is no typical hypometabolism in this case as a temporal lobe epilepsy. So temporal lobe epilepsy is sometimes the clinical features of amnesia occurs, which shows various cognitive deficits, mainly persistent memory impairment, very similar to dementia in the elderly. So we have to keep possibility of epilepsy in diagnosing the dementia cases. Okay, so the fourth case, rather young man, early 50s, He had complained of vertigo for about 5 months. While driving a car, he experienced vertigo, resulting in loss of consciousness to unconsciousness, leading to a car accident. He was transported to the emergency hospital, the emergency CT, 50s, which area shows some normality. So diffusion weighted imaging and FLAIR imaging. T2 weighted images. So T2 star. Please take a closer look at the T2 star. T2 star. FDG PET was performed the 13 days later. In this stage, almost he recovered. So, however, some decrease is present. MMSE is 27, within normal limit. Amyloid PET was performed. Negative or positive? Okay. So, what diagnosis is most likely? Cerebral infarct, epilepsy, demyelinating diseases, or vasculitis? Raise your hand. Hi, どうぞ please. D. A. Wrong. Wrong answer. Is there anybody? Please. Yeah, D. Okay, you are correct. This is very not easy case. So answer is vasculitis. So amyloid positivity is demonstrated using the Amicont, our software. So the right temporal area shows high significantly increased accumulation. Go back to the amyloid PET. This area shows a somewhat increase. And so the neuroimage summary is asymmetric multifocal white matter hyperintestines predominantly on the right frontal and the parietal areas on T2 weighted imaging FLAIR. So multiple cerebral microbleeds in the right parietal occipital areas. Hypermetabolism in the right temporal and the parietal occipital areas. Amyloid positive predominantly in the right temporal and the parietal lobes. So this case is cerebral amyloid angiopathy related inflammation and vasculitis. The CARI. A very rare case. So ringed as a relatively rare and aggressive subtype of cerebral amyloidopathy. So amyloid PET is positive in cerebral amyloid angiopathy. Amyloid PET accumulates in the amyloid deposits in the vasculature, is a blood vessel, artery. And diverse clinical representations characteristic radiological findings. The CARI shares pathological characteristics of CAA, which is A-beta deposition in the cortical or leptomeningeal vessels with positive conglomerate staining. In these days, we can use the amyloid PET instead of the conglomerate staining. In addition to A-beta deposition, CARI also demonstrates pronounced perivascular or transmural inflammatory infiltration, CARI. So in this case, age is 50, and consciousness disturbance occurs, and multifocal white matter hyperlesions are present, and several microbleed was observed. So it match the clinical pathological radiological criteria of CARI. So in this case, T2 star is very important. You can see microbleeds here and here are very tiny microbleeds are present. And around here, the amyloid accumulates. Amyloid PET shows accumulation. And also in the frontal area shows a microbleed. So it's an emergency stage. So you can see multiple white matter hyperintensity. And steroid pulse therapy was performed in this case. So this multifocal hyperintensity almost disappeared. So however, in the FDG PET, still some metabolic decrease is present. So some abnormality persists in this case. Okay, thank you for your attention.
Because time is limited, so we need to close the section. 我们感谢那个马自达教授办一个那个